Welcome to the first Wednesday meeting for the second half of the year. We can see everyone's still adjusting, or maybe it's the cold that's delaying everyone to crawl out of bed. Today is grand round from the Urogyn department. We just want to try and see if you guys can have a focused approach to this patient. Okay, so I'll leave it to Dr. Jowry to start us off.
Morning, everyone. So I start off with so we have a 21-year-old who presents to the clinic with a history of pain and difficulty having sexual intercourse. So what is the further history that you would like to take from this patient?
Nyameka.
I'd like to know, in terms of the history of the presenting complaint, when did the pain start? Is it an acute or chronic? Is it a pain that is persistent or cyclic pain? Is it associated with menses? Okay. Is it associated with menses? Where is the pain exactly? Is it in the abdomen? Is it during intercourse? Is it superficial kind of pain, or is it deep pain in the pelvis? In terms of the sexual difficulty in sexual intercourse, is it difficult because she's experiencing pain? Is it difficult because it's difficult to be penetrated? Is she dry? Is she experiencing any dryness during intercourse? Another issue would be, now I'll move on to associated symptoms, any bowel symptoms that she's experiencing at the moment, any urinary symptoms, and then I'll move further to history. In terms of gynae history, when was her menarche? Did she developed, like in terms of puberty, was it regarded as normal? The menses, are they regular, associated with pain? Any gynecological procedure that she had before? Any? Yes, yeah. And in terms of gynae, what else? Yes, procedures. In terms of obstetrics, any history of does she previously had any pregnancies, deliveries, and details in terms of the method of delivery, any problems with delivery or complications? Yes. And then in terms of past medical history, I'd like to know if she's on any treatment for anything, any psychological issues, psychiatric issues before, in terms of any medication that she's on, or was she ever on, and also in terms of gynae, I'd like to add if she's on any hormonal treatment as well.
Okay, Masondo, anything you want to add? Maybe I'll just clarify the case vignette. It's pain and difficulty during sexual intercourse.
Well,
The English, sorry.
I think she was asking for pelvic pain, and yet it's really about the pain during.
I did ask about whether the pain was in the pelvis, the location of the pain, and whether it was.
No, when you started talking about menses and not focusing on that, so your menses came before. Chantal get my stuff.
So, Masunda? And then just be careful. You said you want to ask the patient about puberty if it was normal. She doesn't know what that is in terms of you got to specify what age was each stage of puberty. Okay.
I would correlate with the other female. I would ask maybe when like to correlate with other females and the siblings, mom, was
Okay.
it regarded as normal?
Okay.
in
Masunda?
terms of-
Yeah, I think the main thing would be the issue of having intercourse. Maybe it's difficult for her to have
Just
the
add
relationship.
issues, so you said what you said, don't repeat. It's okay.
And then the next thing would be, has she ever had any bleeding? And then the issue of birth. I think the birth history would also be important in this young girl. During birth, was there any issues around the genitalia being obviously female or male around those things? I'm not sure if she may have that information, or it's something I can get from the collateral
Mhm.
of these patients. And yeah, immediately after birth, if she was sick and needed admission, severely dehydrated. I think it's from the mom that collateral history that I can get. So yeah, and then I think that's some of the information that I'd like to know.
Okay. Let's move on.
So the history that we have is that she attempted sexual intercourse for the first time, but experienced significant pain and difficulty during vaginal penetration. In terms of breast development, it started at the age of 11. Pubic and axillary hair growth started around the same age. So she never had her menses. There was no cyclical pain, no urinary symptoms, no medical or surgical history of significance. She's not on any medications, and there is no family history of delayed puberty. So in terms of her birth, she was born at term, and she is the only child. So now how would you proceed to examine this patient?
Media?
So from general appearance of the patient, so you want to look at her stature, you want to do your baseline vital signs, BP, heart rate.
When you say stature, what are you looking for?
I'm looking if there are any obvious morphological dysmorphic features that you can see on her. And also your
Which dysmorphic features?
like a short stage, maybe like she may be having like it's not
Just want to look at her height.
yeah, I just gonna look at the sides, height, if she's short or she's tall.
Mm-hmm.
And like I'm looking for like a achondroplasia condition. And also look at the BMI of her, the height and the weight to see if she's overweight or low BMI. And then I will proceed to do a thyroid and neck examination to see if there's any thyroid conditions that she may have. I will look if she has an enlarged thyroid gland or not. I will move on to also look for the features of hyperandrogenism, which will be hitchhiking, also the voice and the distribution of the hair on the chest, look if there's any chest deformities on her, and I'll listen to her chest and look for if there are any cardiovascular abnormalities. And I will do focused abdominal examination. I'll look her abdomen if it's distended or not. Try to palpate if there are any pelvic organs that I can feel.
So if she have had a sex, also I can insert a speculum.
What else on the abdomen?
Yeah.
I will do a bimanual examination to assess if I can feel any pelvic masses, maybe palpate the uterus.
By way of means your hand, at the below, I'm still on the abdomen.
What else?
Anyone else want to help?
Maybe. If there is a mass, there will be a distension and I'll palpate a mass. And then if there is a mass, I'll try and describe according to size, location, and pain.
And as well as we interrupt Dr. Naika.
Mm.
She mustn't be just general, if there's
Yeah.
a mass, so if there's a mass, I'm particularly looking for X.
Yeah, we want to know that you're
Yes,
not
it
just
is.
doing a normal abdominal examination. We want to know on this particular patient, if you are doing an abdominal examination, what are you looking for or trying to exclude? Yeah.
Others can help. Let's do a proper examination. And I think please interrupt them, Dr. Naika, if there are things as they come from head to toe and they're missing.
Yeah,
And go to
okay.
the next person.
So while you're simmering on the abdominal examination, do you want to go back to your general appearance of the patient, what you were thinking? Anyone else want to add? Even from neck downwards? We're probing now and prompting a little bit, so hopefully it's clicking. Marlon?
We also want to have a stage. It's 21.
Hannah's, yes, you have to mention that you want, yes, even though the history, she says she did have some development, you have to still confirm that. Okay, so that's the one. What else?
If phenotypically she looks a female,
Yes.
like distribution, not sure. She mentioned like distribution.
Mm-hmm.
In terms of genetic chromosomal
Speak louder, yeah.
Signs of conditions like Turner.
Which are which signs?
Um,
That's what Prof was asking earlier.
Third stage are low hairline, weak neck, and abnormality of the chest.
What's the abnormality of it?
Shows,
Yes.
shows like chest. Yes, and also you would also want to check for cardiovascular exam because also they are prone to cardiovascular abnormalities like coarctation. Yes, so you would also check the cardiovascular system.
Mm-hmm.
And the abdomen is the mass, the location of the mass, because we concerned about mass coming from the pelvis, which may be due to outflow obstruction and collection of the menstrual blood within the uterus.
Mm-hmm.
Yes, then describe the mass, and also outflow obstruction. On inspection, where the mass is localized, if there's any association with inguinal swelling as well, checking if there's a possibility of testis or gonads somewhere along the inguinal.
Mm-hmm.
And the same way we did tennis for the breast, we need to do tennis for the head.
Yeah.
For the
hair
head.
shape.
Yeah, so it's not only about how much hair growth, it's also the pattern. Okay, so that's important. For Turner's, don't forget it's wide space, the nipples. And the angle of the. Okay, can carry on. Okay, now you can go back to the pelvis. Yeah. No, go back. Since that's where you're all gunning for. So let's, Makwa, anything you want to, what would you be interested in looking for, excluding on the,
Well, starting my inspection of the external genitalia, already mentioned the age distribution
Mhm.
on the pubis. So you look at the external genitalia, they look like a typical female, look at the size of the clitoris. And then you look at the hymen to see if it's intact, separated.
before you get to the hymen?
Labia, the
Mhm.
size of the labia,
Right.
age distribution here as well.
Why do you want to assess the labia?
So it's just part of determining whether it's a phenotypical female or it may be a
Beside that, even if she's phenotypically female?
also if it's not fused.
Okay, yes. You can get labial fusion. What else? Remember, you don't have the, well, I know you had a glimpse of the findings, but technically you don't have the findings. So you don't know yet what our assessment is of this patient. So you need to still think out, you still need to be broad and not try and go down one.
Masses, lesions, painful ulcers that explain the pain that she might have described earlier on during sexual intercourse.
Okay. And is someone pre-pubertal versus someone post-puberty or someone exposed to estrogen, does the labia look the same or different? Right, so you can appreciate that, whether it's underdeveloped, can still be phenotypically female, but you need to appreciate whether the labia is developed or not. You have to be specific because there's minora and majora, so you need to identify that. Okay, what else?
So we say to inspect the hymen first to see if it's perforated or not. If it is not perforated, you look at the character of it. Does it look like there's a bulge? Does it look shiny and thin, indicating that it doesn't get any perforated hymen? Does it? Yeah. A bit thicker, even on and try and do it gentle digital exam to see if there's any pain or tenderness, or if the membrane is a bit higher on in the vagina, just at the level of the hymen. And if it is, if you can do a digital exam, then you do a vaginal exam. You can still appreciate transverse or septum higher up in the vagina, which
Okay.
could explain some of the pain that you might be feeling. There's no obstruction or the vaginal canal is intact. Do a proper bimanual exam to appreciate the size of the uterus, see if you can either see any adnexal masses or any tenderness as you're doing the examination. If you cannot do a digital exam with the vagina, you can also do a rectal exam or bimanual exam with the female rectum and see if you can appreciate what the any masses.
Okay. Good.
So the physical examination was as follows. Blood pressure of 110/70, pulse of 80, febrile. During this dipstick, there was no protein, leukocyte, or nitrites. Her height was 165 centimeters with a BMI of 29. No hirsutism. Breast development was Tanner 5. Pubic and axillary hair Tanner 5. The abdomen was non-tender and there was no palpable mass. On pelvic examination, she had a normal-looking vulva. Clitoris was of normal size. A labia majora and minora appeared normal. The urethral opening appeared normal in the normal position. A vaginal exam, she had a blind ending vaginal canal of 2 centimeters. There was no bulging. A rectal examination was carried out and there was no obvious palpable uterus.
Okay, so I think just from a stepwise, you did the external examination of the labia and the clitoris. We must mention the urethra because part of the, if you're thinking of some structural abnormality, you know that the urinary tract can also be involved. And before you jump to a hymen, you need to first inspect the introitus. Is it a common opening? Is it one perineal opening? So these are the things you need to think about. Okay, and don't forget, some of our patients have underwent genital mutilation. Okay, so those are the things that could be iatrogenic and can affect the anatomy. All right, okay.
So this is a pictures of how the external genitalia looked. A normal clitoris, a labias, minora and majora look normal. The hair distribution is normal. And on the last picture, we can see the vaginal opening, which is in the normal position, with the anus also in the normal position.
Are we showing picture of the same patient or different patient?
No, it's one patient. It's just
One,
one.
yeah.
One.
Huh?
It's the same patient.
Same patient.
Yeah,
Not,
yeah.
not the one that we discussed.
Same patient.
Same patient.
Yeah.
So here we have a summary of the findings. So we have a patient with primary amenorrhea, a second sexual characteristics which are present, an external genitalia of a normal female, a blind ending vagina, and with difficulty of penetration vaginally. So at this point, what are the differentials you will be thinking of?
So we'll leave the little summary of the patient. So this is like her problem list, kind of. So Masondo, differentials, plural.
So, yeah, I think the vagina and secondary sexual characteristics are what develop with the woman actually. It's just that the development of the diffusion there when vagina not properly formed. So the second one then would be insensitivity, androgen insensitivity. Because these patients have the receptors, there's an issue in of testosterone. They tend to have normal sexual developmental characteristics of a female when they are actually males when you look at their catch type. So they all have a blind ending vagina as well, and typically females. So those are the two main differentials, and then the other ones would be, even though in terms of history, so it's not counted a little bit down syndrome like Turner syndrome, though we don't have those phenotypical features.
Right.
But it's still one of the differentials.
Okay. Well, beside the phenotypical, anything else beside the web neck, etc. of Tanner's? What else is missing? Is not in.
Definition, the blind ending vagina, you have those ones who have the one vagina.
Okay.
And the other syndromes also.
So remember, it's differential. So even if it's not likely, but there's a possibility, you can still mention and say what are the negatives.
The outward tracts obstruction.
Mm-hmm.
So it may be interpreted hymen or your vaginal septum. But the negative findings that's on the abdominal examination, because those one, they will have signs of obstruction when you do abdominal examination. They'll have distension because of the retrograde of menstruation.
Okay.
So I'll also add those one.
Okay. Anyone else want to add anything? Okay, so you were correct. The top of our list is Mayer-Rokitansky-Kusterhauser syndrome. And just to clarify, it means that it's an absent vagina, cervix, and uterus, or very underdeveloped uterus. Then you've got complete androgen insensitivity syndrome. I think you must specify, because partial is normally more associated with ambiguous genitalia or a patient presenting as a DSD patient, whereas the complete androgen insensitivity looks phenotypically female with secondary sexual characteristics that have developed. Okay. Then I've put vaginal agenesis, meaning it's isolated. So the patient could have a normal uterus, but no vaginal tract, okay, that has formed. Less common than Mayer-Rokitansky, but it can be something to consider. And like Zama mentioned, but this patient didn't have clinical features suggesting a outflow tract obstruction, okay, or a hematocorpus or hematometria. Okay, all right. So then that would include the transverse vaginal septum. Imperforate hymen, we didn't see that bluish discolor, the bulging at the level of the hymen, or any tense collection there. And then in terms of sexual dysfunction and having penetrative difficulty, the longitudinal vaginal septum, but then that patient you would expect to have menstruated. So they shouldn't have an outflow tract obstruction, but they would have an obstruction for vaginal penetration. Okay.
This layer can see should mention that instead of just mirroring the Agenesis, or what value does that add out? Because terms must be self-explanatory. If you're using terms that are just confusing, I'm not sure what's the value of that.
I think if you are going to, the reason we still use that term is because it encompasses the entire, when you use it, it means the entire malaria, the patient has complete Müllerian agenesis. Whereas if you have a patient with different levels where you're talking about like the uterine septums and cervical agenesis, then you can use the American Society of Reproductive Medicine to classify the different types. So because in this particular patient, we focused on her symptoms and how her clinical picture is, we didn't go down those abnormalities. We focused on the most common association with her symptoms and signs.
But
Yeah.
vaginal agenesis.
I'm not saying that. Vaginal agenesis and Müllerian agenesis, two different things. Müllerian agenesis means that the whole Müllerian system is agenetic, and it can be agenetic at different levels. Here we are saying it's Müllerian agenesis. That's what the whole story is. And I'm just saying, I don't know why we're complicating. I mean, it's like in the past, you said missed abortion. It was not self-explanatory. That's why the term went away. And we came to a term that's self-explanatory. That's what medicine is about, communicating in a way that's easier for people to grasp what you're talking about. I'm just saying that I know where we're saying that, but I think it's just complicating simple something.
Okay. So what relevant, so that's your differentials now. So what relevant investigations are you going to perform? And ideally, I want to hear it in order of how you would perform them. Okay. So I don't want just a list of investigations. I want the specific investigations that are going to help you rule out your differentials. Sonia Meka.
I'll start with ultrasound, since our first is the Müllerian agenesis.
Okay.
To check if the patient has uterus.
Okay.
Cervix, because we expecting she's got normal secondary sexual characteristics. She's a female, but if there is Müllerian agenesis, there won't be a uterus. Cervix.
Okay, good. Right. So you've got your pelvic ultrasound. Both her ovaries were identified. They looked morphologically like an ovary. They were normal size and normal appearance. However, unable to identify a uterus or a cervix or vagina during the pelvic ultrasound. So what is your next investigation? Okay, all right.
You can see if it's for this XX or this is XY.
Okay. So we did the karyotype. She's 46XX. Then what? Only. What's your next investigation? Yes.
I'll do hormonal growth.
Which hormones?
Yeah, you'll do follicle stimulating hormone, lutein hormone, prolactin, and testosterone.
Why are you doing a prolactin?
No, okay. It's not really because I'm not thinking in prolactin hormone. Okay, so the LH and the testosterone.
Okay. So I think the hormones are still relevant. We know you will do a karyotype, but we know the karyotype also takes a couple of weeks to get that result. So you would, at that setting, after you've performed the ultrasound, you would do the karyotype as well as the hormones. Okay. And I want just remember, you don't just because one of her symptoms is primary amenorrhea does not mean you start doing a whole battery of tests. Okay. So we need focused investigations. All right. So like we said, she's 46XX and she had a normal FSH and LH. Her estradiol was normal female and testosterone levels was also normal female. Okay.
Just wasting more resources.
We wouldn't have had her karyotype yet. So there were more resources wasted. We only showed you.
Yeah, I mean, the FSH alone is not.
So,
Testosterone, don't need this factor. I really.
so at the time that you do the karyotype, you don't know her karyotype. So at this point, she could have been a complete androgen insensitivity versus MRKH. So the estradiol and the testosterone would tell you that this patient is the reason she's feminized is because of the high level of testosterone in a CAIS that is now being converted to estrogen, or and the other is why if part of the menstruating, sometimes you do get a sort of dual pathology. So it's possible that she has a uterus, but it's not functional, and that could be because she's anovulatory. So yes, but it's not always accurate. So you have to look at it in entirety. So this is so at this point, in order, if karyotype was easily accessible in terms of time frame that you get the result, then you wouldn't need to do so many tests. Okay. However, when this patient was referred, she already had a thyroid function test, prolactin, so we've already we've already wasted resources. So I think we need to appreciate that these were you shouldn't do more than this for the patient. Okay. Okay, so now we know the diagnosis is Yugi.
I can't say the word, but malaria Agenesis. Yeah.
Okay, so just to simplify everything for everyone, when you were trying to go through everything that we found, we just created a table so that this is what should be going through your thought processes in your little algorithm when you have a patient who presents with primary amenorrhea and sexual dysfunction. So you've got your MRKH, which is a 46XX. So you can separate them according to karyotype, and then you can look at whether they have a uterus or not. And then pubic hair distribution, you can see with the complete androgen insensitivity, they often have sparse hair growth or absent hair growth compared to the females, genetically females. Okay. And then the testosterone levels can also be of value, especially with the CAIS patient. And then just the other clinical features that differentiate the different cases. Okay. All right, so that's fine. All right. Would you do any other add-on investigations now that you have this diagnosis?
Doing abdominal ultrasound to assess the kidneys.
Okay,
System that could be they could be associated with autism.
okay, good. Anything else?
Farada?
Hmm?
You waiting for other?
Yeah, yeah. Anybody else? So only the renal ultrasound, nothing else? Anyone online want to chip in?
Morning,
Hi.
Dr. Sole here. Looking at the diagnosis now, she's type 1 MRKH. So if we thought she's type 2, then maybe you do the ultrasound to check for kidneys. Is it a horseshoe kidney? Or the other thing you can do is an X-ray of the spine to check if there's any vertebral issues. Does she have scoliosis?
Okay, good.
Yes.
Why are you doing an MRI, Masondo? You mentioned it, so you must defend.
Patient's issue here is that during sexual pain, and I think as part of the workup here going towards addressing those problems, I'd like to know how severe is this anatomy, and how I can actually help me in terms of how I can manage it further.
What are you looking for? What's the MRI
So-
to show you that the ultrasound can show you?
Yeah,
Examination can show you. That was so that we learn. How much is it that you?
It's important because often you'll get caught in the trap that you see us requesting investigations, but you don't know the reason behind it. So you just reflex think it must be done, but you need to understand why you are doing it. Is it going to add any value to your management? So, so if you have the luxury of MRI easily accessible, would you request the MRI and why?
That information would you tell us that it's not that big? Not sure.
Okay, you can do a pelvic MRI, okay, because they can have rudimentary horns that you may not appreciate on the ultrasound, and this can help you in counseling your patient and planning the surgery. You know, today with surgery, you can't just go in and say you're planning one procedure and you see something else and you want to do an add-on opportunistic procedure. You need to plan and inform your patient that you saw a rudimentary horn and you excised it. And what does that mean? You know, a lot of our patients, they hear there is a horn, they think it's functional. So you need to be able to counsel these patients. Okay. It's not a must-have, but it's a nice to have. Okay. All right. So like you rightfully said, Dr. Makwa, the renal ultrasound is important, and Dr. Sitole, about the skeletal exam assessment. All right. So you can see with Malarian agenesis, there is 30 to 40% of patients that have an associated renal tract anomaly. All right. And then with whereas the skeletal abnormalities are not as common, but still significant at 10 to 12%. You don't need to order an echo for every patient, but you should have done a cardiac assessment because ASDs, VSDs, those are things you can appreciate on examination. And if you suspect it, then you can do further testing. All right. And embryologically, the development of the ear is also happening at the same time as the development of
This is a very
the genital
condition,
tract.
condition that needs a multidisciplinary healing.
So it's important to inquire about her hearing, okay, in terms of hearing impairment. All right. So now what is your further management? Who wants to give it a go?
Counsel the patient on the diagnosis and what This means in terms of like future fertility implications, not having a uterus cervix. So that she understands and so address that issue, but also address sexual, like the pain during intercourse, because that can be addressed. So you would also, sorry, so you want to assess like help with the issue of pain during intercourse. So there are methods to help create a vaginal canal so that it's not painful and she can still have a relatively normal.
What are these options that you are giving the patient now?
You could offer her dilation. But it would come out.
Okay, okay, we'll give it to somebody else now. Yamika?
After counseling, you would offer her or counseling on available options.
Mm-hmm.
Non-surgical options.
What are you addressing now that you're teaching options?
We've already discussed with her that in terms of intercourse, this is why she has difficulties. So this is if her concerns are intercourse and pain. So we're addressing that in terms of addressing the short vagina.
Mm-hmm.
In terms of fertility, we will counsel her that she won't be able to carry her own child. There's an option of surrogate because she's got ovaries
Mm-hmm.
that are functional.
Mm-hmm.
So that there is an option of oocyte harvesting and surrogate
Mm-hmm.
if she's able to afford to, or we help her to access that.
Okay.
Yes, non-surgical will be first counsel her that she may continue to try and do it naturally with the
Partner.
using.
It's a realistic,
Yes, and another option is to use the dilators.
Okay, before we move on, anything someone wants to add, Masondo?
Because of technology that usually involves with these difficulties in engaging with intercourse, and I think it's important to make that it's equality.
Yes, so just remember, don't forget that this is a complex patient. You need a multidisciplinary team, and the psychological support is one of the main, your first forefront interventions that you will implement. You can't offer her anything if she hasn't yet dealt with the list of issues this disease, the syndrome has will impact her. Okay, so you got to go through all of that. All right, it's fine. You have a problem list and you're like, okay, for problem A, we're going to do this. So we can't do anything for problem B. So this is what I'm going to do when she hasn't yet dealt with the diagnosis. All right. So don't forget the counseling. All right. So, all right. So now you've dealt with the counseling, the infertility. The only thing you can offer her is to try and improve sexual function or give her some form of normal sexual function or try to achieve that. So now what are your options? So now you can elaborate, Nyameka.
We talked about dilatation using dilators.
Okay, so non-surgical versus surgical, right? Okay. So what are you going to tell her? So remember, you have the patient. Even if you're going to refer her to someone else for further intervention, you still need to give her the tools to make some sort of decision or have an idea about what are these things you're mentioning, so then she can decide. So when you tell her there's non-surgical versus surgical, and you just say the one option is you can dilate, the other option someone can cut you. We'll go further into that just now, but how is she going to decide which one is beneficial to her? What are you going to tell her?
It depends what she accepts, because the dilatation will depend on how committed she'll be in terms of doing that every day, be consistent with using dialysis myself.
Mm-hmm.
It's worth it to now.
Okay.
I can't remember.
Success rate
Is
of
it
that.
successful? Is it
I'm
worth doing or a waste of time? Because dilators also cost money.
I'm not sure about the percentage of success in terms of the dilators.
Okay.
Yeah. So if that is acceptable and she's committed to doing that, then we can try it. And other surgical procedures
Mm-hmm.
that we can offer, that we can create a vagina for her. And if there are people that with expertise to do that,
Mm-hmm.
different procedures. One that comes to mind is the use of the patient's skin, autologous skin, using a mold and creating a tunnel between, I forgot the word, tunnel between the vagina and the rectum. And you use autologous skin with the mold and create a new vagina.
Mm-hmm.
And the other one is the vacuity,
Mm-hmm.
where we use the peritoneum. I can't remember. Let me continue to think someone else last week. I'm gonna confuse.
Who wants to give it a go? She was doing okay. Got anxious.
You start with the
What is the
basic
vacuity?
to the more complicated. No. Least invasive to the more complicated. The one of using skins and what and foul and all, it's more complicated. So like easier things to do, but that's the one that was trying to describe down. Brown baby.
Okay, for the interest of time, right? So we mentioned counseling, we said psychosocial, psychological support, and then obviously discussing whether in terms of sexual function is essentially all we can offer from a gynecological perspective. Okay, so in terms of an intervention, all right, in this particular patient, we opted for the laparoscopic vacuity procedure. Okay, which she was agreeable to, and she had the procedure done. Okay, so for those of you that don't know the vacuity procedure, it is a surgically performed procedure. However, the mechanism is just traction. So it's similar to vaginal dilatation, but vaginal dilatation relies on the patient to be performing the itself performed, right? So that's more difficult to sort of adhere to, etc. So the vacuity still uses a traction device, so that essentially in that operation, you already achieve some sort of stretching, and then it's maintaining the vaginal dilatation thereafter. All right, does that make sense? Okay, versus the other procedures, we're going to come to the other options in Dr. Jerkut's talk. So for now, we just want to show you what has happened to this patient. So this is the device. You can see there's these big, scary needles. You've got something very small that's called the olive that goes into the vagina. And these are called dummies that you attach for the appropriate vaginal length that you're trying to achieve. So you can see as you increase traction, you will see them disappearing into the introitus. And then on this side, you've got the moles, which we only use post procedure. And this is the traction device. Okay, so this is where your sutures will be hooked onto the patient's abdomen, and then that circular knob is where you increase the traction. Okay, so you need these dummies so that you can see how much traction you... We're giving more pictures from. Yeah. Okay. So originally the vacuity was an open procedure, and then it got modified. There are different variations to the detailed steps of the procedure, but overall it's still quite similar to the original. Okay, so these are just the laparoscopic equipment that you will require for the procedure. And then just a closer look at the olive, which is the initial part on the left, and you can see the smaller attachments are what we call dummies. So that's how you can quantify how many centimeters you have of traction you have created. Okay, and vaginal length. And then this is it's a suture carrier, and the needle that you're going to traverse through that blind ending vagina into the abdominal cavity. Okay. So you do need someone experienced, because obviously these are quite, someone who doesn't have control, you can easily cause lots of trauma to the patient. Okay. All right. So then this is the device that sits on the abdomen. Okay. And then just to conceptualize for you guys, hopefully this helps. Okay. You can see the operator is inserting that needle with a non-absorbable sutures through the needle capturer, that opening. All right. And then you push it through the blind ending vagina, and laparoscopically you will retrieve those sutures, and then that's what's going to be pierced through the abdomen. Okay. So normally you don't have to do any dissections and things inside the abdominal cavity. It's just that it's basically under direct vision that you can perform this procedure. Okay. All right.
So I explained that the codes are going to go where the finger is, isn't it?
Yes. We do have more pictures, but hopefully this video shows you. So this is just laparoscopically, you can see there's no Mullerian structure. You can only see the round, the uterosacral ligaments and nothing else. And this is what you would identify in this patient, and you can see ovaries. Okay.
Are those tubes?
They do have tubes, yeah.
When you say there are those tubes.
The fallopian tubes, but we didn't focus on the rest of the anatomy and more the procedure. Yes.
Yeah, but of that.
So now you can see the operator this is not this patient's procedure. I just put disclaimer because of time. The patient we discussed was done recently, so we haven't had time to edit all the videos. So here you can see the needle piercing from the vaginal end. Okay, so you can see we haven't done any reflection of any structures. So you can, if you are not, you can easily pierce the bladder or the rectum in these patients. Okay. So now you have to retrieve the sutures, because it's two sutures that will pull through to create your traction. So and then here you can see the olive that is going to be pulled into the vagina. Okay. Sorry, someone scribbled there. I don't know. Okay, so here you can, so now we're trying to retrieve the suture from the abdominal cavity. All right, so we're reintroducing the needle, the trocar into the abdominal cavity to try and retrieve the suture extraperitoneally, so that there's minimal suture material lying free in the abdominal cavity. Okay. So someone is holding the camera, so it's under direct vision, because you can easily injure the inferior epigastric vessels during this part. Okay, so now you're hooking the suture back. Oh, we're almost out of time. So now you can see on either side of the abdomen, you've got the two strings.
Because they start with the smallest size for the application.
sorry, I should have pressed pause. This is the end. So what we do is we create traction on the day of the procedure, about 6 to 8 centimeters. All right. And then every day we increase the traction by about 1 centimeter, all right, in the ward. And then on day 7, we remove the traction device. Okay. So this video was now showing you that the traction device was being removed. We've taken out the olive, and she's now got a patent vaginal opening. And now we will insert the vaginal mold. Okay. So you can see the size of that mold that is being inserted. Okay. So the mold will stay in for a couple of days, where she can now take it out when she's going to the bathroom, etc., and reinsert it, and then you transition to dilators. So even if your patient is not irrespective of what procedure you opt for, your patient has to be motivated to do vaginal dilatation. It's just when you offer non-surgical, there's more pain and discomfort when there's no tract, and a lot of motivation to sort of increase that pressure. Okay. Maybe Dr. Jerkert can quickly just go through the other options, because we only have a few minutes. The traction device, 7 days. Yeah. Yeah.
Yeah, they can pick the other one.
So good morning, everyone. We'll move on to the management options for vaginal agenesis. So it is a rare congenital anomaly. The estimated incidence is 1 in 4,500 female births. It is characterized by the absence or underdevelopment of the vaginal canal, which impacts reproduction and sexual health. There's significant physical, emotional, and psychological challenges for those affected. It is associated with conditions such as the Rokitansky syndrome or androgen insensitivity syndrome. The management involves a multidisciplinary team, clinical psychologist, and intervention for the creation of a neovagina. So the women with Rokitansky syndrome of 46XX karyotype with hypoplasia of the vagina and uterus due to embryological failure of the Mullerian ducts, while those with androgen sensitive syndrome are 46XY, and they have a defective androgen receptors, which results in inability of development of male's secondary characteristics. And this patient should be evaluated for congenital anomalies. Up to 50% of those with Mullerian agenesis have concomitant skeletal or urinary tract congenital malformations. So with regards to the urinary tract anomalies, it is 27 to 53%, and up to 32% with the skeletal abnormalities, which namely are scoliosis and other vertebral anomalies. This patient usually present as primary amenorrhea, despite normal secondary sexual characteristics, and may report difficulty with vaginal penetration. So management is surgical and non-surgical. The timing of intervention often poses a challenge and is deferred until early adulthood with an attempt to align treatment once psychological maturity is reached. The benefit of delaying intervention allows for the patient to be directly involved in decision-making and thereby ensuring adherence to post-treatment protocols. Non-surgical methods, namely the Frank method, it involves progressive use of vaginal dilators. The reported success rate ranges from 69 to 95% with self-vaginal dilatation. Adequate motivation is needed to endure pain and discomfort. This technique has also been modified by inserting the dilator on a saddle of a bicycle, and which gently generates perineal pressure. Despite 92% success rates, many patients complain that the technique was uncomfortable. The cost of dilatation versus vaginoplasty was reviewed by Ruth et al., and they found that even with dilatation failures that required further surgery, dilatation was still more cost-effective. And ACOG recommends dilatation as first line for vaginal agenesis. But there are numerous surgical methods that have been described in literature, with each their own unique characteristics, advantages, and disadvantages. Namely, the Mackinder, which uses the skin graft mold, the Vecchieti, which is a vaginal traction technique, the Baldwin uses a segment of a bowel, and Davidov uses peritoneum. Just briefly on the Mackinder, it uses split thickness skin and involves the creation of a vaginal space followed by suturing a skin graft around the mold. The skin is then harvested. The skin is harvested with the aid of the plastic surgery team. A transverse incision is made between the rectum and the urethra, ensuring sufficient dissection to accommodate the mold, whilst care must be taken to avoid entering the peritoneal cavity. Patients need to be extensively counseled on prolonged use of the mold. Functional success has been reported to be as high as 89.5%. The lack of compliance results in contracture and vaginal length reduction. Complications rates are low, but usually are bladder and rectal perforation, fistula formation, and graft infection. The Vecchieti procedure, which is a traction technique, was first described in 1965, involves gradual stretching of the patient's own vaginal skin and mucosa by steady traction and followed by progressive dilatation with mold. The laparoscopic assisted approach was introduced in the 1980s, and the anatomic success with variations of this technique is as 99 to 100% and reported functionality of 92 to 96%. Vaginal length achieved after 11 months post Vecchieti procedure has been reported to be as high as 6 centimeters. No, more than 6 centimeters. And post-surgical outcomes also make this technique favorable for those with access to uterine transplantation. So this was, we'll skip the steps because it has already been described in the interest of time. The next option would be Davidov vaginoplasty. Involves combined laparoscopic and vaginal approach utilizing peritoneum from the pouch of the glass to facilitate neovaginal accretion. It has favorable anatomic and sexual outcomes, ranging from 90 to 95%. The mean vaginal length has been reported to be 8.3 centimeters after 6 months, and sexual function outcomes appear to be comparable to women without Rokitansky syndrome. And sigmoid colon vaginoplasty has also been described, and it is more frequently performed as a revision surgery following previous vaginoplasty procedures. This method achieves the desired vaginal depth and minimizes shrinkage and narrowing over time. So most sigmoid colon resembles the natural vaginal mucosa appearance and provides natural lubrication through mucosal secretions. Proximity to the vaginal canal, long mesentery, lower secretion levels, wider lumen, and more durable mucosa makes it particularly suited for this procedure. Significant amount of discharge is produced in the first 3 to 6 months due to the intestinal mucosa. The complications are rare, but include fistula formation, flap necrosis, intra-abdominal bleeding, rectal perforation, blood injury, ileus, and necrotizing colitis. So to conclude, the features of an ideal vaginoplasty include minimal complications during and after surgery, ease of procedure, rapid recovery, adequate depth and width, aesthetically pleasing appearance. The best method has yet to be determined through randomized controlled trials, as current techniques are not dictated by evidence, but solely by surgeon experience. Conservative approach should initially be considered, and ultimately the decision to proceed with a new vagina rests upon the young woman affected and the treating team. And with that, I conclude. Thank you for your attention.
Thanks, everybody, for being patient. I know we went over time a bit, but hopefully you got a decent overview. And I think it is important for the registrars to know the different techniques. You don't have to know the steps of every technique, but you need to be aware of the options available. All right. Any questions?
They are not focusing. Their history is all over. We can't be at point still talking how to approach. Your introduction was how to approach history. I mean, this case. And our history was all over. Our examination was all over. We can't be prompting and prompting and from the examiner. You know, there's somebody who's written to the college and said they were not prompted. Where in the script does it say that we should be prompted? So, and the history we got today instead of, you know, final year, some of the final years actually, really, they come up and they tell you what they're looking for. And that's what you expect from the regime. When I examine, I'm looking for this. Because if it was this, you understand. And we've said these things. I don't know why you want us to. Then you say we shame you at the resource. No, we are not. We are trying to get out of what you know, but you are not taking it out.
And we kind of purposefully didn't say presented with primary amenorrhea because that would have taken them down a much longer pathway, which we were trying to avoid. So we tried to say it was.
The vignette was clear, pain and difficulty on intercourse. It was not pelvic pain, no abdomen. So when the history started going there, that's when I had to say, no, let's focus. So it means that you really have to read what are you given and what are people. Otherwise, you can spend 15 minutes preparing on a tangent like that. And then you're going to struggle because you then expect to be prompted and so forth. So I think for me, I was a bit disappointed in the history and examination.
No announcements, Prof? Okay, thanks, everybody.
Recording stopped.